Well, good evening, ladies and gentlemen. I have to tell you about Adrian Owen. He particularly wanted me to mention that he was a prefect at Gray's Inn School. For some reason, that was something he has not on his CV usually. However, our first conversation was when he got me to guess the nature, the phenotype of a man in a scanner without actually looking at him. And I was able to work out that he was 5'4" high, that he was a male, that he had a moustache, that he was, I think, white, if I remember correctly, and that he had a mole on the inside of his left buttock, simply by answering the question whether or not he was going to imagine playing tennis. Well, Adrian will explain all that to you, no doubt, in a second. It's wonderful to introduce him. He did his first degree at UCL, and then went to King's, and then spent time at McGill University, having been at Cambridge, and then back in Cambridge again. And in 2011, he went to the University of Western Ontario, where he's currently Canada Excellence Research Chair. And it's my pleasure to introduce him to talk about the search for consciousness.
Thank you very much, Lord Winston, for that generous introduction, especially the bit about me being a prefect. It's Gray's Inn Grammar School for boys, actually. Also, thanks to the British Neuroscience Association for inviting me to give this talk. Now, consciousness is very difficult to work on consciousness, mainly because none of us can really agree on what the term actually means. Clinically, it's a little bit simpler because consciousness really only refers to two quite distinct things, wakefulness and awareness. Today I'm going to demonstrate that these two different components of consciousness are separable. Imagine, for example, what happens when you have a general anesthetic. You start to close your eyes, you start to lose wakefulness, but you also stop being aware of where you are and who you are and the predicament that you're in. You start to lose awareness. And we can measure these two things differently. I'm going to tell you a little bit about that too. And they are dissociable. We can lose one of those things without losing the other. Let me start by talking about measurement. So wakefulness is the easiest component of consciousness to measure. We can do it just behaviorally by looking at each other. If I look at all of you in the audience, your eyes are open, and on that basis, I know that you are awake. If you want to get a little bit more scientific about it, you can use a technique like electroencephalography or EEG. We can put electrodes on your scalp, and we can measure the electrical activity coming from your brain. Now, the awake brain has a particular characteristic pattern of electrical activity, so even if you had your eyes closed, I could detect that you were awake using a technique like EEG. Awareness isn't like that at all. The awareness component of consciousness is much, much harder to measure. I can't just look at all of you and know that you are aware. In fact, the only way we have of measuring or detecting that somebody is really aware is by asking them. And clinically, we refer to this as command following. So there's a lot of you here. I can't really see you, but I'll do a quick public demonstration. I want you all to do exactly what I'm about to say. Please raise your left arm into the air. Wonderful. Great. You can put it down again. Well done. So you have all witnessed their command following. I issued a command, please raise your left arm, and you all did it. And on that basis, I can conclude that you are aware. You're following the plot of what is going on in this particular shared situation that you and I are in. But actually, I can conclude much more than that. I can conclude things like, well, you understand spoken language because I issued the command and you did what I said. I can conclude that some aspects of your memory must be intact. You all know what your left arm is, where it is, and what putting it up in the air means. You can also translate a command that you hear into a thought, into an intention to act, and push that on, translate that into an action. So actually just this simple response, a simple response to command, can tell us quite a lot about how intact somebody's cognitive faculties or processes might be. But what about if you do not respond to command? What can we conclude on the basis of a lack of command following? And the canonical population of patients who do not command follow are those who are in the so-called vegetative state. Now, vegetative state is not like coma. Coma patients have eyes closed. And as you're going to see from this short video, vegetative patients will often open their eyes. In fact, they often have intact sleeping and waking cycles. They'll go to sleep, they might snore, they wake up, they have roving eye movements, they look around the room. They won't fixate on anything in particular, but importantly, they will never respond to a command. That's the absolute important characteristic for a correct diagnosis of the vegetative state. So as you can see in this video, this is a rather infamous vegetative patient. She's waking up in this video. She's opening her eyes. And this is the confusing thing about this condition. The patients are, again, unlike coma patients, they are animate. They move. In some senses, they behave. And this can be very seductive in trying to work out what is going on for them. The problem is, because they do not command follow, we are forced to conclude, following the logic that I've outlined in my introduction, we're forced to conclude that they are not aware. And this population of patients are often referred to as awake, but unaware. But what if any of these patients were actually aware? What if they were just incapable of generating a physical response to command? Well, what I'm going to suggest is that if that was the case, we would have no way of knowing that they were aware. If they couldn't respond to command, as I've said, as I've shown you through the demonstration, if you can't physically act, if you can't respond, then how could we possibly detect that such a patient is aware? Now, this is not just an interesting scientific problem. It's actually, for some of these patients, it's a genuine matter of life and death. It doesn't seem these days as though a week goes by without an article in the newspaper describing a court case where decisions are being made about the withdrawal of nutrition and hydration in a patient who is supposedly in a vegetative state. This is exceedingly common, both in Canada, where I now work, back here in the UK, and actually all over the world. And the decisions often the arguments are often between family members, one of whom would like to see the patient go, another family member might not want to see the family go, or between the clinical group who are looking after the patient, who think the patient should be allowed to die, but the family want to keep the patient alive. But in most of these cases, the central issue revolves around whether the patient has any awareness of what is going on. And generally, the court case also rests, particularly in cases where the patient is allowed to die, on the assumption that the patient has no awareness anyway. So in a sense, they have no sense of what is going on. So this question is really central, the question of awareness. And it's very, very clear that we're not very good at assessing whether patients are actually aware or not, and that's clearly important to many of these cases. So for the last 15 years or so, working at the MRC Cognition and Brain Sciences unit in Cambridge, and then more recently at the University of Western Ontario, my group have been using Fmri, functional magnetic resonance imaging, and some electroencephalography to try and develop methods of detecting command following in order to detect awareness, but not physical command following using just in most cases, just the patient's brain. The general philosophy, and this is a technique that we developed about 10 years ago now, is that we put the patient into the scanner, and then we ask them to imagine a scenario. And we ask them to imagine a scenario that we know a lot about, and that is imagining playing tennis. Now, the reasons why we do that are not because we're particularly interested in the tennis-playing areas of the brain, even if there are tennis-playing areas of the brain. It's because this is a very simple scenario that can allow healthy participants and patients to imagine something, in this case, imagine making very large and vigorous arm movements without needing to provide a lot of instructions. We don't tell people how to imagine playing tennis. We don't remind them what tennis is. We just say, imagine that you're playing tennis. When you do that, in healthy participants, what you see is a band of activity across the premotor cortex. Now, of course, the motor cortex doesn't activate because the people don't actually move in the scanner. They don't actually move as if to play tennis. They're just imagining it. So what you're getting is the premotor cortex sending the preparation signal to the motor cortex. Prepare to move. It's a very reliable response. It's also a sustained response. By getting people to imagine they're playing a game of tennis, we can get them to keep doing this, in most cases, for about 30 seconds at a time. In fact, the activity, you see it there across the premotor cortex, typically is sustained until we tell the participant to simply relax. Now, the reason that we've stuck with this very simple paradigm for so many years is because it's extremely reliable. We've scanned hundreds and hundreds of people now, simply asking them to imagine playing tennis or to relax. This is actually from the first 8 volunteers we ever scanned. What you're looking at now is a sagittal view, a view from the side of the head, looking at that band of activity. What you see is it's almost exactly the same in every individual, even though presumably they're imagining playing tennis in slightly different ways, in slightly different places, and so on and so forth. The activity in premotor cortex is extremely reliable. And as I say, typically we can get people to keep this activity sustained in the absence of any additional activity. Now, on this basis, I would argue that something as simple as imagining playing tennis in an Fmri scanner is as reliable as asking somebody to raise their arm. I was very lucky that, as far as I could tell, all of you actually raised your left hand when I asked you to. And it's extremely rarely that we scan a healthy participant and they aren't able to activate the premotor cortex when we ask them to. I think what surprised most of us back in 2006 was how quickly we would find a patient who was in a vegetative state who would produce this type of activity. So we came across, this in fact was the first patient we ever tried this with. She was a woman who'd been involved she was a pedestrian, she'd been in a road traffic accident, she'd been hit by 2 cars, and she had a very serious brain injury, and she had been in a vegetative state for 5 months. So for 5 months, she had produced no physical responses to any form of activity. She had sleeping and waking cycles. She would open her eyes. She had roving eye movements. She was very typical vegetative state patient in that sense. Where she was extraordinary is in what happened when we asked her to imagine playing tennis in the Fmri scanner. We saw, again, this is a view from the side, a sagittal view. Again, we saw activity in her premotor cortex that at the time was indistinguishable from the activity that we saw in the group of healthy participants that we had at the time. Now, I know some of you here will have no or very little Fmri experience, so I want to make a very simple point, but important point, very clear to you, that what you're looking at here is not a simple instant in time. This is not something that could have just happened by chance. This is a statistical representation of a number of repeated activities or changes in her brain activity that she was able to make every time we asked her to imagine playing tennis. So actually, this is a 5-minute period, and we had 30-second bursts where we said, relax, tennis, relax, tennis, relax, tennis. And as you can see, every time she hears the word tennis, activity in this area of the premotor cortex, the area that we know is involved when people imagine playing tennis, turns on. When she relaxes, it switches off. So there was replication in here. She could do this and she could stop doing it. She could do it and she could stop doing it. Also, it's sustained, and this again is really important, that this was not we didn't have to continually stimulate her. We just had to give her one word, the word tennis, and her activity over a 30-second period was sustained. She could keep up this activity in the premotor cortex. Now, on the basis of these results, we concluded that she wasn't vegetative at all, that actually she was aware and she was conscious. And the reasons for doing that were actually rather straightforward. And it's not because she could simply produce this pattern of activity, but because of what is required cognitively to produce this pattern of activity. So for this to have occurred, we were able to conclude, again, as I said with you, that she could understand spoken language. She understood the instruction to imagine playing tennis. Clearly, aspects of her long-term memory were intact. She remembered what tennis was. We didn't tell her that. Her short-term memory or her working memory was intact because she could remember the instructions that when she heard a word, she was supposed to act on that word. She could clearly switch attention between relaxing and playing tennis. She could sustain attention over a 5-minute 5-minute scanning period. I could go on and on and on. It's very hard, actually, to find a complex cognitive operation that is not required in order to generate a robust and reliable activation pattern like that by simply being asked to imagine playing tennis. And all of these cognitive processes, the things I've mentioned, are all part and parcel of what we think of as being one's normal conscious awareness. These are all things that we use all day, every day, just to get through our daily activities. And these are the reasons why we felt that we could conclude that this woman was aware. Now, we've gone on to test a lot of patients using this task. I'm going to show you a short television clip from one of these patients. It just gives you a little bit better idea of how it actually works. So in the 10 years since we started this, things have changed quite a lot. We now have real-time Fmri, so this happens while the patient is still in the scanner. We know if the patient is aware, we find out while they're in the scanner. It happens actually pretty quickly. So this is the video. In the video is a patient called Scott. I'll tell you a little bit about Scott. He again was involved in a road accident 12 years before we scanned him. He'd been very carefully and extensively studied over 12 years, and nobody had concluded that he was anything other than vegetative. He was a teenager when he was in the accident. So at the start of the video, this is the start of the thing you're about to see. I don't know whether Scott is in a vegetative state or is not in a vegetative state. The assumption is that he is, because that's what we have been told. But it's about a 2-minute video, and you'll see how things unfold. Scott, right, this is your big chance. We really want you to try as hard as you can to imagine playing tennis for us. Okay, we're going to ask you to imagine playing tennis quite a few times while you're in the scanner. And if you can do that, then we'll be able to see your brain activating. So I want you to imagine you're standing on a tennis court and moving your arm around as much as you can. All right, so we're going to put you in the scanner now. Just do your best. Stay awake.
This is a big challenge for brain-injured patients. It requires hearing, recall, understanding, a functioning mind.
Okay, Scott, it's Adrian speaking, and we're ready to start the first scan. This is where I want you to imagine that you're playing tennis.
Tennis.
Okay, we've got a little bit of activity there. Okay, yeah, we've got something. Okay, this is what we want here. Okay, so we've definitely got more activity than we had previously.
Something remarkable is happening. Confounding more than a decade of medical assessments, Scott is responding in the scanner.
On tennis, yeah. That's looking pretty good, actually.
That's quite striking, isn't it?
Yeah.
Scott's been in the scanner more than an hour and needs a rest, but the team feel his responses clearly suggest awareness.
So that was Scott, and that was the first time that we were able to show that that was the first evidence that we had after over a decade of investigations that Scott wasn't in a vegetative state, but he was actually aware. And I'm going to talk a little bit more about Scott at the end of my talk, because he actually became a very important patient for us. We went on to see him many, many times over a 17-month period, and we acquired an awful lot of information about the situation that he was in. But I'll come back to that a little bit later in my talk. We've scanned quite a few patients trying this technique. They come to us, typically they have a diagnosis of vegetative state. About almost 1 in 5, almost 20% of the patients who are referred to us, and this is true both from the UK cohort and a similar sized cohort that we have now in Canada, about 1 in 5 of these patients who are entirely non-responsive outside the scanner. At the bedside, no responses to command. In the Fmri scanner, they will reliably produce these patterns of activity that are indicative of them being in some other state, of them being aware and able to command follow, albeit command follow with their brains. Now, I want to talk about 2 sort of new issues that we've been trying to tackle recently, and it has to do with trying to, or at least one of them has to do with trying to work out how many patients this might be applicable to. Now, clearly, MRI is a non-portable technique. We have a very special group of patients. In some ways, they're self-selected. The patients that we see are the patients who are able to travel. They're able to come by ambulance, or in some cases by plane, to London, Ontario. They're able to lie still in an MRI scanner for sometimes an hour at a time. These are not really representative of these patients at large. There are thousands and thousands of patients in this situation in every town of the Western world, for sure. And they're in care homes, they're in their own homes, they're sometimes in hospitals, and many of them aren't able to travel. So we have been working on ways of making this technology, making our ability to detect awareness portable and a little bit more economical. To do that, we've used electroencephalography, or EEG, or ERPs. We have our wittily named EEG that travels all over Ontario, visiting patients. And it's essentially, the technique is the same. We use electrodes placed on the outside of the head, and we ask the patients to imagine a scenario. Now, it turns out that tennis playing doesn't work very well for EEG. Typically, we use a scenario like imagine squeezing one of your hands, or imagine moving your feet. Those 2 things are more easily discernible using EEG than having people imagine playing tennis. But broadly speaking, the results are about the same. About 1 in 5 of the patients that we now go out and select ourselves, we visit them, and about 1 in 5 of them will produce patterns of activity when asked to imagine squeezing their hands or squeezing their toes. They'll produce patterns of activity that are similar to healthy participants. Up here. Now, I will say that the EEG technique is far from perfect. It is not as reliable as Fmri, and we know that from healthy participants. Some healthy participants are not able to produce a good EEG response, whereas, as I've already said to you, almost everybody that I've ever scanned imagining playing tennis will produce activity in their premotor cortex. But I think this is promising, and at least it allows us to get access to a much larger group of patients. The problem, though, with both the EEG and the Fmri is they both still rely on command following, and this is the second issue I'm going to touch upon now, and this is our most recent work in this area. The problem with command following, it's very easy, I think, for most of us to imagine that a patient might not be able to do these tasks. Getting into a scanner, having an EEG cap on, imagining switching from one task to the other, imagining playing tennis, these are all cognitively quite demanding things. And many of these patients clearly have had serious brain damage and may have diminished cognitive abilities. And it's quite plausible, I think, in fact, it's almost certainly the case that many patients will have some level of awareness, but may nevertheless be unable to command follow, even using their brains. So let me introduce you to Jeff. This is Jeff and his father, Paul. Now, Jeff is, again, a very interesting patient. When Jeff was a teenager, he was attacked, and he was kicked in the chest and had a cardiac arrest as a result, and ended up with oxygen deprivation to his brain, leading to a vegetative state. He's now about 35. It's 17 years later. Jeff, again, has been repeatedly diagnosed as being in a vegetative state. Now, when Jeff and his father Paul came to visit us at Western, I had quite a long conversation with his father, and he told me that every week for this entire 17-year period, he had taken Jeff to the movies, to the cinema, to see all sorts of different films. So I said to Paul, well, why do you do that? You know, your son's in a vegetative state. And he said, well, you never know, do you? And then he said, well, actually, he quite enjoys going to the movies. So I said, well, how do you know he enjoys going to the movies? And of course, he said, I just sense it. I can sense that he enjoys going to movies. And this is the message we get from lots of families, that they have this sense that there's more going on for some of these patients than we are able to detect clinically. But most importantly, this gave us an interesting, I think, idea, which is whether we could use the way that people watch movies, or at least the way that one's brain changes when you watch movies, to detect awareness or detect consciousness in a way that didn't require any effort, any command following on the part of the patient. To do this, we turned, of course, to the master movie maker Alfred Hitchcock, or the master of suspense. And actually, I think there's an important reason for that. Alfred Hitchcock's movies, and we used one of his short films, which we shortened even further to be about 8 minutes long. But what's interesting about Alfred Hitchcock movies is they don't really rely on the things that modern movie makers do to sustain interest or engage the audience. So there's not lots of fast cars and loud bangs and very fast, shaky camera work. The suspense or the interest in most Alfred Hitchcock movies is built up by gradually introducing pieces of information that sort of become relevant. So if you take this example, this is from as I say, a short. It was a made-for TV movie. It's about a boy who finds a gun under his father's, under his uncle's bed. It's a real gun. But to really understand this movie, or to engage with this movie, you have to understand that this is a gun, and a gun is something that is dangerous because it kills people, right? So you need this piece of information about the world for this to actually be an engaging or a frightening movie. You also have to have a bit of theory of mind, because you have to realize early on that the child doesn't realize that this is a real gun. He thinks it's a toy gun, because if he didn't know, if he knew it was a real gun, it would be far less scary, because he may have some responsibility for what he did with it. There are no bullets in the gun at the start of the movie, so actually the gun isn't very scary, because even a real gun isn't terribly scary if it doesn't have any bullets in it. And again, we know that because we have that knowledge about the world. He finds bullets, he puts bullets in the gun. You can see where this is going. He ends up roaming around, waving the gun around. It's terribly, terribly, I wouldn't say it's frightening, but there's an awful lot of suspense in this movie. It's very cleverly put together. But the suspense in the movie is built up by all of these pieces of knowledge, all of this theory of mind about what you know about the people in the movie, what you know that they don't know, and what you know about various objects. So to engage with this movie, to engage with the plot of the movie, you really have to understand it. And I think that's central to what I'm now going to tell you. So what's also interesting about this movie is if you scan a group of healthy participants all watching this movie, and you line up all their scans so that all the same parts of the movie occur at the same time, what you see are very high levels of correlation in lots of parts of the brain. Our brain activates in a very similar way if we are all watching this same Alfred Hitchcock movie. So one might conclude that we're having the same general experience. Now, for those of you who don't know anything about Fmri, or indeed may just wonder whether we all have highly correlated brains anyway, I'll just show you this to tell you that this isn't the case. If you scan the same people simply lying in the scanner, not watching a movie, no part of your brain will be correlated with your neighbor. Now, it's important that you understand that we're looking at correlations here. I'm not telling you that your brain will not be activated, but that activation will not correlate with another person lying in a scanner for the same period of time. Now, In order to try and understand what some of these correlations meant, the first thing we do, and I should say this is work by one of my postdocs, Lorena Narchi. And what Lorena did is she scrambled the movie. She cut it up into little sections. So the plot didn't make any sense anymore. You still had all the same elements, the same sounds, the same visual information, but the plot no longer made any sense. And of course, there wasn't much suspense because the plot made no sense. And when she did that, what you saw is that the correlations in the primary auditory and visual areas remained the same. And again, that's because you're seeing the same stuff and you're hearing the same stuff. So those correlations are still there. But all of this activity in the frontal lobe and in the parietal lobe disappeared. They were no longer correlated. Even though everybody in the scanner still experienced the same thing, but the plot was gone. And this gave us the first clue that this could be a really important way for detecting people's engagement in a plot like this. But we had to sort of quantify it in a much more rigorous way. And to do that, we did two things. First, we took a group, and I don't really have a lot of time to explain this in detail. I encourage you to go and read the paper that came out last year in the Proceedings of the National Academy if you're really interested. But I'll explain it briefly. We took a group of healthy participants, and we got them to watch the movie outside of the scanner. And we got them to rate how suspenseful it was. That's all they were told. Every few seconds, they had to rate how suspenseful it was. And you won't be surprised that at the point that the kid points the gun directly at the screen, that's the most suspenseful moment in the entire movie. Other points when the gun has been recovered at the end of the movie are not at all suspenseful. Again, there were very high correlations between individuals over how suspenseful they thought this movie was. What was really surprising to us, though, is that this rating of suspense predicted or correlated highly with activity in the frontal lobe and in the parietal lobe of a separate group of participants who were lying in the scanner watching the movie. So the activity in those parts of the brain is related to how suspenseful you are finding the movie. In fact, it's related to how suspenseful another group of people is finding that movie at the same period of time. Now, the problem we use the term suspenseful because it's hard to come up with a terminology that people will understand what you're asking them to do. And the problem with suspenseful is, of course, there are other aspects, more basic aspects of a movie that make it suspenseful that aren't necessarily to do with the plot. So a second method that we used was to get people to do another task while watching the movie. So again, we had a separate group of participants, not in the scanner, and they were doing a very, very simple button pressing task. And our logic here was that the more engrossing or engaging the movie would be at any particular point in time, the more you got into the plot, the less cognitive resources you would have to apply to this secondary task. And the worse you would get at that task. So by getting an estimate of the performance of the secondary task while people were watching the movie, we came up with a measure of how engaging the movie was at every single second of this 8-minute movie. And that's what you're looking at in this second row here, that again, what was surprising, I think, is that how engaging the movie was very highly correlated. In fact, it could predict activity in the frontal lobes and in the parietal lobes of an entirely separate group of participants. So what this means in a nutshell is that by simply watching a movie, by looking at people's activity in parietal and frontal lobe, we can determine the extent to which they are being drawn in by or following or engaged by the plot of a movie. And I am going to try and extrapolate beyond that and say that this is a pretty good analog, if you like, to the extent to which somebody could be engaged with events that are unfolding in their own lives. So let's go back to Jeff. As I said, 17 years he's been going to the movies with his dad. This is Jeff at the bottom here. And what we did is we tried to predict where we put Jeff in the scanner, we showed him the same Alfred Hitchcock movie, and on the basis of the ratings of healthy participants outside of the scanner, the suspense ratings and the engagement ratings, we tried to predict where Jeff's brain would activate, at what time it would activate during the movie, if he was engaged in the same way that healthy participants are. That's the simplest way I can put this. And what happened is Jeff's activity was extremely similar to healthy participants who are watching this same movie. Of course, Jeff had activity in auditory cortex and in visual cortex, again, similarly to participants. But what was really important is he had these same changing patterns of fronto and parietal activity that we concluded were indicative of the fact that Jeff was following the plot. And if he can follow the plot of a movie, then we concluded that Jeff was probably able to follow the plot of his own life. Now, again, I could talk about Jeff a little bit later. Jeff went on, this was the first evidence we had that he was actually aware, he wasn't in a vegetative state, and he went on to perform a whole bunch of different tasks in the Fmri scanner later, and we had sort of supplementary or secondary evidence that that he was aware. But this was the way that we, in a sense, discovered that this was, after 17 years of going to the movies, all of his father's efforts really were not in vain. Now, it's not true of all vegetative patients, of course. In the paper, we compared a second patient, a patient who was very similar to Jeff, hadn't been in a vegetative state for 17 years, but was nevertheless clinically rather similar. This patient had the same basic auditory responses to the movie that healthy participants have, but had no activity in the fronto and parietal cortex, indicative of the fact they might be following the plot. So the point here really is, I think this is the first measure that we have of detecting awareness in the absence of any behavior that is relatively effortless. It might sound like quite a lot of hassle to put a patient in a scanner and play them an Alfred Hitchcock movie, but actually compared to getting them to imagine playing tennis, it's a breeze. And it's certainly something that we can distribute much more widely and is easily usable by people in other centres. I'll sort of end by, I'll get at least towards the end, by talking about communication. Now, most of you who don't know this work already will have thought this through, I'm sure, will have thought, well, why can't they use this to actually communicate with patients who are in a vegetative state? And this was a fairly minor theoretical move on from the original tennis playing task. And the idea here is to just take two tasks that a participant can do in the scanner. There are many things other than imagining playing tennis that we've used over the years. So let's call them task 1 and task 2. As long as they produce really quite clearly different patterns of brain activity, it doesn't matter what those tasks are. It doesn't even matter which parts of the brain they activate. As long as they repeatedly and reliably activate the same pattern and those two patterns are rather different, what you can then do is just say to the patient, well, we know you're there, we know you're aware, we're going to ask you some questions, and we want you to do one of those tasks to convey a yes and the other task to convey a no. This was from the first patient that we scanned. This was a collaborative study with Stephen Lorries and his colleagues in Belgium. They had a patient who had been in a vegetative state for 5 years, again, a vehicle accident. This was a driver in a vehicle accident. We established that the guy was conscious after 5 years. We asked him to imagine one of these tasks for a yes and another task for no, and then we asked him a series of questions. Now, this was the first time we'd ever tried anything like this, so obviously we didn't ask just random questions. We asked questions that we could go back and verify later. We had information from the family about things like the names of his family members. So when we said, "Is your father's name Thomas?" We saw that pattern of activity. Those two things, especially to those of you at the back, they may look identical, but these are quite different scans taken at quite different points in time. One of them is him imagining a particular task, and the other of them is him answering this question when he knows that to do that he has to imagine task 2. In this case, of course, he's conveying a no, and we were able to verify that his father's name wasn't Thomas. Compare that to the pattern we saw when we said, "Is your father's name Alexander?" And again, there the pattern was completely different. It looked much like the pattern that he had been taught, if you like, to generate in order to answer yes. And this patient went on to answer a whole series of questions like that. Now, with other patients subsequently, once we established that this works. Of course, it's not very interesting to keep asking people what their father's name and whether they have brothers and sisters and things. We could just go and ask the family that. When it gets really interesting is when you start asking questions that you don't know the answers to. I'm just going to give a couple of examples here. We've tried lots of different things. One thing that we do frequently now is to try and ask questions that are relevant to improving a patient's immediate situation, if you like, improving their quality of life. One thing that happens to these patients all the time, I'm sure you can imagine, is they get put into situations a lot involving things that they used to enjoy or things that their relatives thought they used to enjoy. And some patients can end up watching hours and hours of sports on TV simply because they had expressed an interest in sports before they got into this situation. I can imagine that could be quite annoying or distressing. So we've done that. We've also asked patients, are you in any pain? Again, we don't have a way of detecting pain. The only way I can know whether any of you are in pain right now is to ask you to tell me how much pain you are in. With this technique, we can say to patients, are you in pain? We can even find out which part of them is in pain. Are they in physical pain, emotional pain, which part of their body? And of course, if necessary, we can administer analgesics. This is now going back to Scott. Scott was the patient who we, in the BBC Panorama program, we were able to establish was conscious. We went on to test Scott in the scanner many times, ask him many questions. These are some of the examples of things we asked him. We asked him twice whether he was in physical pain, and he said he wasn't. We were very happy about that. It's like a sort of this ends up being a bit like a highly technical 20 questions, but it's surprising how much information you can get out of people when you're just asking them to answer yes and no. So, you can find out obviously things about whether they know what year it is, they know how much time has passed since they had their accident. We investigate aspects of their memory. We ask them about things that have happened since their injury, so we can establish that they're still laying down memories, or perhaps they aren't. We can ask them things that occurred before their injury to establish that their long-term memory is intact. You can even look at simple aspects of high-level cognition. You can ask them to do maths, to solve. We've done reasoning problems with patients. Ask them to solve reasoning problems as long as they can be solved with a binary yes or no response. You can do that sort of thing. And again, there's the quality of life or clinical questions like, are you in pain? And I'm sure you can imagine lots of other questions that one might want to ask some of these patients. And some of them we tried and some of them we haven't, but I'm very happy to answer questions about that. I'm very glad that Robert Winston mentioned his when he came to the Cognition and Brain Sciences unit in Cambridge to try our technique, because I have a short clip of it. Again, it's really just to give you a bit of a flavour of what this is like. I mean, in that program, as he said, what he did is he challenged us really, or he challenged our technique. In the sense that he wanted to try it himself. Is this something that's simple enough for him to be able to read off the Fmri of these participants? So this is, again, a short 2-minute clip just showing you how that unfolded.
Exciting research at the University of Cambridge is using the MRI scanner to see how the mind works.
Robert, hello.
Nice to see you. In the scanner next door is a willing volunteer I've never met.
I want you to face this way.
All right, not to look in the window.
Don't look in the window.
I can't see your subject. By asking some simple yes or no questions, I'm going to try to find out a bit about him or her.
If the person in the scanner is trying to convey a yes, you're going to see a bright red area of activity around his premotor cortex, the supplemental motor area, right at the top in the middle of the head, yeah. If the person in the scanner is trying to convey a no, what you'll see is the same area of the brain will be lighting up, but it'll be a blue-greeny colour.
Are you a man?
There you go. I'm pretty confident that this person is conveying a yes at this stage.
Are you over 6 foot high? He's now got a green area, so this is signalling a no answer, which would mean that actually this man, is not 6 foot high. He's shorter than 6 foot. We can't actually see the brain think yes or no. That would be too difficult even for an MRI machine. What our volunteer was asked to do was to imagine playing tennis when he wants to say yes, And when he does, the area of the brain which deals with movement, his motor cortex, shows increased activity. And that is easy for the MRI to see. And this is our last question. Do you have facial hair? Again, pretty obvious activation. I would say that this guy's either got a beard or a moustache. Hi, thank you so much.
Now, luckily for us, we had chosen a diminutive, hirsute male. Otherwise, the outcome could have been completely different. That's just to sort of give you an example of actually, this is fairly straightforward now. All of the software that we use is shipped with the scanner. This is not some fancy piece of software that we've had to write. And as you saw there, notwithstanding some television editing, it happens in pseudo real time. We can ask questions of a patient while they're in the scanner, and we can get these answers with a very high degree of repeatability and robustness, reliability. So I will just end by telling you about the future, telling you where we're trying to go now. We're really trying to combine all of these different components that I've talked about today. The idea would be to be able to try and construct a true brain-computer interface, something that is portable enough for somebody to wear all the time, perhaps take home with them, economically or cheap enough for this to be something that could be made clinically available. It's clearly going to have to involve some kind of EEG. And it's going to look something like this, I think, at least in the first instance. So this is not a patient. This is a colleague of mine. He's using his EEG. He's imagining different scenarios with the EEG in order to try and influence this ball. The ball appears on the left half of the screen. What he has to do is to hit this target on the right side of the screen. And what you should be able to see from the video is he's actually doing extremely well. I think he only makes one error over a 12-minute video. Now imagine if I were to simply superimpose a yes there and a no there, then this participant could be answering simple yes and no questions exceedingly rapidly, perhaps one every 5 or 6 questions. Now that's clearly not a real conversation, but for a patient who maybe has been decades even, unable to communicate with the outside world, this would be, I think, absolutely, it would make life completely different. It would be an absolutely fantastic addition to their life if they could communicate. And this, obviously, any of you that know anything about brain-computer interfaces can imagine that this could easily be made very much more complicated without any particularly difficult further technical innovations. So the technology is all there. I wish I could end by showing you a patient who could communicate in this way. And right now, I can't show you that. That hasn't happened. That is something for the future. But I can assure you, as is always the case, the future is closer than you think. Thank you very much.
Adrian, thanks very much indeed. You've got recently interested in the dementias in Alzheimer's, Huntington's, and so forth. How does this kind of inform with regard to that kind of brain dysfunction?
Actually, I've got this work on patients who are non-responsive through brain injury. It's got me very interested in really any type of population who may not be everything they appear. So we know, for example, in Alzheimer's disease, that very quickly patients become less able to report their condition. It becomes very difficult to assess them because they can't perform tasks. Now, just because they can't perform a memory task doesn't necessarily mean that their memory is as bad as the task would suggest. So similarly, in some ways, Parkinson's patients, due to their physical disability, it's very often difficult to assess exactly how cognitively impaired they might be because of their physical disability. So we're applying some of these methods, obviously in a rather different way, to some of those populations, really to any population of patients who, where performing a task with a sort of physical output may actually not be the best way to really assess how good their brain is, what residual function they may have in their brain.
Can we have the hall lights up so we can see the audience, perhaps, and maybe you could put your hand up if you want to ask a question. There's some roving microphones around, I think there are about 4 people. If there's no immediate question...
There's one out
you've
there.
got one over there? Okay, yeah, thank you.
Hi. In the patients who were non-responsive, I think roughly 75–80%, you said, was that non-responsive to the tennis question? Or were you able to ask them different questions that they became responsive to? Or were they completely non-responsive to an array of different questions?
Yeah, so we approach this hierarchically. Obviously, you could waste a lot of time and a lot of scanner time and patient's time by simply trying to ask somebody questions. So we sort of gradually work up. We first establish that a patient, we can get some activity out of the patient. Even things as basic as can the patient lie still for the period that's required. Then we ask them to do typically the imagery tasks, or we have other more recent things like watching the movie to establish that we think they are aware, they're not vegetative, and then we move on to the questions. So actually it's typically 2 or 3 scanning sessions before we move on to the questions. So the patients, when I say 80% of patients are not responsive, I mean that we can't get any indication that they are aware from the imaging. They will often produce changes in brain activity to simple stimuli like speech or faces, but they won't respond in a way that allows us to conclude that they are actually aware.
Thank you for that nice talk. Just a question, when you had you've always got the yes or no response, and did you ever encounter patients who were not motivated to answer either yes or no? And what did you do in that kind of situation?
So I think that's a really interesting question, because my question back to you would be, how would I know, right? And that's a really important point, because, and this is why we, and it's relevant to the previous question, we never conclude that a patient is unaware based on a lack of activity. So, you were all kind enough to humour me and raise your arm when I asked you to at the start of this talk, but actually you didn't have to. I suppose there was a certain amount of peer pressure that encouraged you to, but you really didn't have to. It was your choice. And we also know that it's your choice to imagine playing tennis in the scanner. And we know this because, to answer some reviewers' questions, after the 2006 paper came out, we asked a group of healthy participants to not do what they were told to do in the scanner, and then we explicitly said to them, please imagine playing tennis. And we didn't see activity in the premotor cortex. And that's because we're actually rather good at not imagining playing tennis, even when we're told to imagine playing tennis, if we've previously been told not to do what we're being asked to do, right? Because this is under conscious control. This is something that you have to decide to do. And although I think most of us would find it a little odd that a patient would, say, choose not to do it, I can think of reasons why a patient, motivation is one, but actually a patient may choose to not generate that pattern of activity. They may not want to be found or discovered. So really, I don't know. I wouldn't know if a patient hadn't responded. We do see fluctuations. Maybe that's one way of addressing your question. Some days patients are more responsive than others, but we tend to think about that less about motivation and more about perhaps how sensitive our techniques are on a given day.
Thanks a lot for your fantastic talk. What if all these mechanism is just an automatic response of the brain? For example, the language area interpret the sentence, and then when you ask them to play tennis, it just commands the rest, and then the premotor cortex activates. How do you know if they are aware of it or conscious of this aspect?
Yeah, so this is a question I've been asked many, many times over the last 10 years, and I have many, many different answers to it. So I'll just give you a few. The first is the answer I just gave, that you can choose not to do this. Therefore it can't be an automatic response. I can put you in the scanner and I can say to you, imagine playing tennis now, and there won't be a response in your brain if 2 hours ago I told you to not do what you're told in the scanner, right? So we know that the words imagine playing tennis now, even those words do not automatically produce this pattern of activity. You have to decide that you want to do this. In the same way as raise your arm now doesn't automatically make you do that. You have to say, do I want to do what this guy is telling me to do? I guess so, and you do it. So, it isn't automatic, it can't be. I mean, you can, all I can tell you is there is no evidence that it can be, and therefore it's not something that I feel that I need to, consider very much further.
Yeah, thank you very much. I'm interested, do you think there's a common lesion in these people? Do you think there's a site that is blocking their interaction, or do you think there's it's multiple brain regions?
That's a great question. This has been something that we've been really trying very hard to establish. Now, obviously, in some senses, these patients are similar to the classic locked-in syndrome. And locked-in patients have a well-described brainstem lesion that sort of disconnects their output from their thought processes. For those of you who don't know, locked-in patients often have entirely preserved cognition, but they are almost entirely physically incapable of moving, except perhaps moving their eyes or blinking their eyes. These patients that we see are in some kind of complete locked-in situation where they can't even move their eyes, and the suggestion would therefore be perhaps some another kind of brainstem lesion, and that's not something that we have been able to establish. We have a paper in submission at the moment about a particular patient, about Scott, that that we investigated many times in the magnet. And Scott does appear to have a problem, or did appear to have a problem with projection from his thalamus back to motor cortex. So if he is representative of this fairly small group that we've seen to date, then that could be where the problem is.
Yes, I'm a young woman. I was in a coma myself, six weeks, a traumatic brain injury. But the one thing which really confounded the doctor's expectations was the fact that they played music to me. And that, I think, made a big, and also they spoke to me. And my mother gave me shiatsu. I was in the coma. I was totally unconscious. But I think if you had looked at elements there, that would have started making links, associations, and activities in the brain. And I think to relate to that is important.
That's an interesting idea. And in fact, we are, well, two things. One, I didn't have time to talk about coma. Coma is a condition that often precedes the vegetative state. It's what happens immediately after you've had a brain injury or a stroke or cardiac arrest. You have eyes closed, you don't have sleeping and waking cycles. So one thing that we've been doing recently, this is work by Loretta Norton, my PhD student, is trying some of these techniques in coma patients because it's now pretty clear that there are a lot of vegetative patients in this situation, but the idea that some coma patients may have residual cognitive function and even awareness is actually a whole lot more scary, because in that patient group, decisions are made on a daily basis about whether they should continue to live or not. And often the decisions are made on the basis of 30-year-old guidelines that may not be relevant anymore. And actually, I can tell you that we've scanned about 30 patients. We've not published this yet, but we have preliminary evidence that activity in the Fmri scanner in coma in the first few days after injury can have prognostic indications. So patients who are more likely to produce responses, and I'm not talking about people imagining playing tennis while in a coma, that we have yet to see, but certainly patients who are responding to much simpler types of stimulation, including things like music in the MRI scanner, are more likely to go on and make a recovery than those patients who have no fMRI responses.
I was just wondering, you say that you did the test with clearly asking them questions and then following a control afterwards, or following your command afterwards. Have you ever thought about, I'm pretty sure you have, what if they can't hear? I mean, if they were to be able to read or something instead? Yeah,
so again, this sort of, and perhaps I'm sorry I neglected to actually say this in my talk. This comes into the sort of category of things that could happen that would mean you wouldn't want to draw conclusions about a negative response. So typically, if a patient was deaf, now, we can try and rule it out by doing very simple types of stimulation and looking for activity in the auditory cortex. If we can establish that the sound is getting that far, then we might want to conclude that the patient can hear, if you like. But what if they've lost the ability to understand language? They don't understand the instructions that we're giving them. If a patient didn't produce activity, that would be, didn't imagine playing tennis when we asked them, that would be extremely unfortunate. So again, we basically conclude nothing. If a patient doesn't respond in the scanner, we literally say we were not able to conclude any more than if we had never scanned them at all. We don't sort of even edge towards saying they're probably not conscious. We just conclude nothing.
I just have a question about some of the deeper kind of ethical considerations of your work. Particularly, you've asked them questions such as, are you in pain? Have you gone along those kind of very, that kind of ethical minefield of asking a patient where there is a situation where the family are in conflict with the doctors perhaps about whether or not to end the life? Have you gone along those lines or thought about those kind of questions?
So I get asked this all the time by courts mainly, which is why I mentioned the legal thing. I get called at least twice a month now by a lawyer or a court somewhere that has sort of somehow thought ahead and decided that we could just scan their patient and ask them what they want, and then it would all be fine. And the problem is, the reason why we don't do that is because, of course, it wouldn't be fine. Because we don't, as you've alluded to, we don't have a sort of an ethical framework really worked out for what one could do. So technically, yes, we could ask these patients whether they want to live or die. But the problem is, in most civilized cultures, we don't allow perfectly healthy people to just decide whether they want to die, right? We don't have a system that just allows anybody to decide to die. If somebody walked into a doctor's surgery and said, I want to die, the first thing you'd think of was, perhaps they were depressed, or, perhaps tomorrow they won't feel that way. Let's send them away and ask them to come back and make sure they still want to die in 2 weeks' time. There are lots of sort of checks and balances one would want to put in place. You'd want to ask the question in lots of different ways. You'd want to make sure they didn't have some kind of psychiatric illness that was, predisposing them towards these thoughts. All sorts of reasons that, all sorts of things that you would want to investigate, and one does investigate in different contexts, particularly in the context of mental health. Not talking about the patients we're dealing with here. So you'd have to do all these same things with this same patient group, and that would add up right now to an awful lot of scanner time, an awful lot of verifications, and we are in the process of working that out, and because we would like to make recommendations for how one could move forward, partly because a lot of these things are often moved forward by the courts rather than by science. So we'd like to get in first, but it's going to take a long time, I think.
Thank you.
Adrian, thank you very much indeed. It's wonderful to see how the work is moving on since we first met and where it seems to be going. And I suppose one of the many lessons is we should be much more aware of this, that the auditory cortex is working sometimes in people who are often not apparently attending to what you're saying. And that's obviously of very great importance for clinical care. Thank you very much for coming all the way from Western Ontario.
My pleasure.
To the wonderful weather in Edinburgh, which is great. And thank you very much for an excellent lecture.
My pleasure. Thanks.